Welcome, and thank you for joining us today for the webinar, Intervening with Cancer Caregivers to Improve Patient Health Outcomes and Optimize Healthcare Utilization, FOA Reissuance. My name is Stephanie Myers, and I will be your WebEx host. Before I move into introducing our speaker for today, I would like to go over a few things before we get started. All lines have been muted upon entry and will remain muted for the duration of the webinar. Please submit your questions throughout the presentation in the Q&A or chat panel and select all panelists from the dropdown. We will ask them on your behalf during the Q&A portion of the webinar. Questions about specific aims will not be addressed during this webinar. If you need to view live captioning, please refer to the Media Viewer panel. This webinar is being recorded and will be posted online in the near future. And now I'd like to turn it over to Dr. Michelle Malika, who will begin the presentation.
Thank you very much, Stephanie. As Stephanie mentioned, my name is Michelle Malika, and I'm a program director in the Healthcare Delivery Research Program of the National Cancer Institute. Over the next hour, we will present some background on our division and program within the NCI, information about informal cancer caregiving, specifics regarding this funding opportunity announcement, and then we will take your questions regarding this FOA. And again, to reiterate, a note that questions about specific aims or grant application details will not be addressed in today's webinar. We'll start with a background of our division and program within the NCI. This is an organizational chart of all of the extramural divisions within NCI. The Division of Cancer Control and Population Sciences is where we are located. And this is a large division holding a portfolio of about 800 grants and contracts. Our program is the Healthcare Delivery Research Program, which is one of 4 research programs within the division. Other research programs include the Behavioral Research Program, the Epidemiology and Genomics Research Program, and the Surveillance Research Program. The Healthcare Delivery Research Program's main mission is to advance innovative research to improve the delivery of cancer-related care. We have 3 branches, including the Healthcare Assessment Research Branch, which assesses utilization, access, diffusion, and population-based outcomes. The Health Systems and Interventions Research Branch, which supports research to observe and intervene on behavior and context. And the Outcomes Research Branch, where I sit, which has a focus on patients and their caregivers with a mission to support research to evaluate and improve patient experiences and health outcomes. At this point, I'll go into some background information on informal caregiving, caregivers, and specifically caregiving in the cancer context, which led to the development of this FOA. Informal caregivers are individuals that assist family members or friends by providing care which is typically uncompensated, usually occurs in the home setting, and involves significant efforts of care for an extended period of time. Being a caregiver is really characterized by the tasks that caregivers take on, which can be many and varied. Examples include monitoring for side effects, managing symptom burden, helping their care recipient make treatment decisions, coordinating care among healthcare providers, as well as triaging care, which is making decisions about whether an emergent health issue requires immediate medical attention, and administering medications. Finally, caregivers often manage a care recipient's financial and social obligations in concert with their own. Caregiving in the context of cancer presents unique aspects that are worthy of mentioning here. Cancer in and of itself is many diseases, and patients often receive multimodal therapies. Cancer patients can experience more variability in symptoms and toxicities from these therapies than do individuals with other chronic illnesses. This can necessitate that their caregivers monitor the care recipient's health status frequently and use a variety of technical and psychosocial skills to promote patient health. Cancer caregivers typically spend more hours per day providing care and provide more intense care over a shorter period of time as compared to other care recipients with chronic illnesses. This presents a high burden for providing care. In addition, the unique points specific to the cancer care continuum, including diagnosis, treatment, transition off treatment, survivorship, as well as end of life, lead to variability in the level of care burden and ongoing adjustments unique for cancer caregivers. Finally, a unique hallmark of cancer is the possibility of recurrence, which is stressful for both patients and caregivers alike. So it's not surprising that many cancer caregivers report cancer-specific stress that has a measurable impact on cancer caregiver health and well-being. In addition to the stress on caregivers themselves, cancer patients also report concern about how cancer may have a negative impact on their family members and caregivers. There have been several recent efforts to advance research and set priorities in cancer caregiving. In 2016, the National Alliance for Caregiving, in partnership with the National Cancer Institute and the cancer support community, published a report called Cancer Caregiving in the U.S., which was based on data from the 2015 Caregiving in the U.S. study. The study was based on an online probability sample of caregivers, and cancer caregiving in the U.S. compared to those who report caring for an individual with cancer to those who cared for individuals with other health problems. This report found that about 2.8 million adults were currently serving as a caregiver to an adult with cancer, caring on average 32.9 hours a week. In addition, 43% of cancer caregivers reported performing complex medical nursing tasks without any prior preparation, and 50% report high emotional stress. Finally, 25% of caregivers reported high levels of financial strain. And these results underscore the impact of the cancer experience on caregivers and the need for interventions that address their unmet needs. In 2015, colleagues from both the NCI and the National Institute for Nursing Research led a two-day meeting with over 75 attendees to discuss the state of the science, research, and clinical priorities for informal cancer caregiving. The results of that meeting were published in the journal Cancer. The key areas of focus and resulting recommendations that were covered in that meeting and subsequent paper are as follows: expanding assessment of prevalence and burden of cancer caregiving, maximizing the positive impact of technology in the realm of cancer caregiving, facilitating further integration of caregivers into the healthcare system, and improving interventions for cancer caregivers and patients. In this area of improving interventions, it was noted that there was a need to prioritize health outcomes of interest, improve definitions of constructs, examine effects of interventions on patient and caregiver outcomes, and replicate interventions that show benefit and attend to fidelity and dose consideration. This area of improving interventions led to the original development of this funding announcement. To address the gap of improving interventions, NCI developed an FOA focused on cancer caregivers, with the purpose of focusing on interventions that examine strategies to support cancer caregivers to improve patient and caregiver outcomes. Through the original PAR, we were able to fund 9 awards, which includes 4 R01s, 1 R37, and 4 R21s. The R37 is a merit award for early-stage investigators. It is awarded to ESIs who submit an R01 application and receive a score within the NCI pay line and are endorsed by NCI leadership and the National Cancer Advisory Board. You can see that this initiative has stimulated a lot of successful applications. It has also stimulated several collaborations among multiple disciplines to design interventions aimed at improving patient health, caregiver well-being, and optimizing healthcare utilization. We analyzed the applications to the previous PAR, however, which demonstrated a continued need to fund applications in this area. We're excited to say that PAR has now been reissued, and at this point I'll cover the details of the current FOA. So PAR 19-352 and 355, entitled Intervening with Cancer Caregivers to Improve Patient and Caregiver Health Outcomes and Optimize Healthcare Utilization, is intended to support interventions that examine strategies to provide caregivers with training, promote coping skills, and ultimately help them manage their care. Outcomes of the interventions should aim to improve patient health, caregiver well-being, and optimize healthcare utilization. Applications in response to the funding announcement will be in one of two mechanisms, the R01 and the R21 grant mechanism. Most of you may be familiar with these mechanisms, but just to review, the R01 is one of the most commonly used grant mechanisms. It supports a discrete, specified, and circumscribed research project. There is no specific dollar limit, but advance permission is needed for over $500,000 in direct costs in any 1 year, and the R01 supports 3 to 5 years of funding. The R21 grant mechanism supports newer exploratory and developmental research projects and can be used for pilot and feasibility studies. The combined budget typically may not exceed $275,000 over the total and supports up to 2 years of funding. So at this point, we'll go through some application requirements. First, the interventions must be delivered to at least the caregiver, though interventions can also be delivered to the patient and care recipient and caregiver dyad. Applications should focus on caregivers of patients ages 21 and over at the time of diagnosis, and we encourage you to refer to RFA CA 19033, which focuses on intervention of pediatric cancer populations and does include a component for caregivers. In addition, patients must be at the point of diagnosis forward on the cancer control continuum. Studies conducted with patients in active treatment, transitioning into survivorship with advanced cancer, or at the end of life are acceptable. Research projects appropriate for this FOA are expected to include outcomes in the following 3 areas. Cancer patient health outcomes, which can include behavioral, physical, and/or psychosocial morbidity, at least one caregiver well-being outcome, and at least one health utilization outcome. And this can include patient readmissions to the hospital, number of emergency room visits, caregiver use of services, and caregiver use of cancer support services. Research projects should aim to identify intervention components that make them effective, including the conceptual framework, timing of and content of the intervention, as well as dosage. Investigators are encouraged to consider the potential for sustainability and scalability in the development, design, and testing of interventions. Transdisciplinary approaches that bring together clinical and scientific fields that interface the most with cancer caregiving, including nursing, social sciences, and health services research, are encouraged. In addition, collaboration of diverse stakeholders such as clinicians, researchers, and caregivers in the development of interventions is also encouraged. Studies targeting or expanding inclusion of medically or minority underserved patient caregiver populations will be given special consideration under this FOA. Use of randomized controlled trials and/or pragmatic trial designs is strongly encouraged. Applications may include mixed methods approaches to determine the most effective components in the context of the intervention. And finally, applications may or may not include the development and testing of tools to evaluate caregiving, although the focus should be on the development and testing of an intervention. Applications not considered appropriate for this FOA include those focusing on caregivers of pediatric populations, applications proposing observational research only, and those focused on cancer patients or survivors only, not including a caregiver population. In addition to describing the proposed project using the standard subsections, investigators applying for this FOA must address all of the specific aspects listed here. First, a clear definition of the target cancer patient caregiver population, as well as an indication of how the project addresses persistent and salient problems for the specified population. inclusion of a research team with appropriate caregiving science and health services expertise, a description of how the intervention will balance improvements targeted in all three outcome areas of healthcare utilization, caregiver well-being, and patient health, and a strategy for how the intervention, if successful, will be appropriately disseminated. Review criteria specific to this FOA in the area of significance is, does this project address persistent and salient challenges that the targeted cancer patient or caregiver population faces? How amenable is the proposed intervention for dissemination and implementation? Under the investigator review criteria, how strong is the research team, including representation of appropriate caregiving and health services expertise? And under approach, does the intervention appropriately balance improvements targeted in all three outcome areas, as we've previously stated? As this PAR requires intervention studies, please note the updated NIH requirements for clinical trials research applications. The link at the bottom of this page has very useful information about these requirements. In terms of budget, as with any grant application, the budget should reflect the actual needs of the proposed project. For the R01 mechanism, advance permission is required for over $500,000 in direct costs in any year. And for the R21 specific to this FOA, the combined budget for direct costs for the 2-year project may not exceed $275,000, with no more than $200,000 requested in any single year. You'll see some key resources here. First, we suggest that you read the FOA very carefully. In addition, the previous PAR had 2 receipt dates per year, but this reissued PAR is moving to standard due dates. The first due date is special, so we alert you to see that PAR 19352, the R01 mechanism, new, renewal, and resubmissions are due on October 17th, and thereafter standard due dates apply. And for the R21 mechanism, new submissions are due on October 16th, with resubmissions due in November 16th. Thereafter, standard due dates apply. The webinar and FAQ from today's webinar will be posted on our website, and we encourage you to connect with us early. In summary, today we presented on PAR 19, 352, and 355, intervening with cancer caregivers to improve patient and caregiver health outcomes and optimize healthcare utilization. The announcement is designed to fund interventions that support the success of informal cancer caregivers for adult cancer patients as measured by improved patient health, improved caregiver well-being, and optimized healthcare utilization. We encourage you to read the online announcements carefully. Contact us with any questions and the specific aims of your project that you might be considering. Consider applying.
Thank you, Michelle. I'd now like to jump into our questions from our audience. And as a reminder, you can ask a question by typing it into the Q&A or the chat box and submitting or selecting all panelists.
So the first question is, for clarification, is this FOA only for pediatric patients or caregivers or for adults?
Thank you for this question. So this FOA refers to caregivers of care recipients that were diagnosed with cancer at ages 21 and older. Again, as noted in the webinar, we refer you to the current pediatric RFA, which does include caregiver populations of pediatric care recipients. For those applications, you must intervene with the caregiver and care recipient dyad in the pediatric RFA.
Okay. The second question is, how broadly defined is caregiver in terms of this FOA?
Sure. So we have not specified a definition of caregivers within the FOA. We intend it to be broad, but it's up to the researcher to determine their operational definition of cancer caregiver and to support that with a rationale in their application.
Okay, the next question is, can you please clarify the receipt dates?
Sure, absolutely. So we're moving from previously having 2 receipt dates in April and October to standard receipt dates. The first receipt date of October is a little bit different, so I'd encourage you to look at the FOA for specific details on that.
Okay, next question is, are multiple PI submissions possible and or encouraged?
So multiple PI submissions are definitely possible and acceptable, but they are not required.
Next we have, are we allowed to use novel technologies in this?
Sure. So this FOA was written very broadly. So as long as it meets the acceptable considerations, as we noted in this webinar and in the FOA, that novel technologies would be acceptable.
Next question is, are applications welcome across all cancer sites and phases of care?
Yes. So there is a requirement for the phase of the cancer care continuum from the point of diagnosis forward, but otherwise all aspects and phases of the cancer care continuum as well as cancer sites would be acceptable. We'd encourage the investigators to really provide a strong rationale in their application for why they chose the phase on the cancer care continuum and the cancer sites that they chose.
Next we have, are foreign institutions allowed to respond to this FOA?
Foreign institutions are not allowed to respond to this FOA.
Next we have, does the application apply to cancer caregivers in hospice and palliative care?
Yes, it does.
Next we have, do applications need to target all three types of outcomes, patient, caregiver, and healthcare utilization?
Yes. So there is a requirement in the FOA to target all three levels of outcomes. We leave it up to the investigator to balance those outcomes. So not all need to be primary outcomes. Some could be exploratory based on their intervention and conceptual framework.
Next is, what is the review process after the scientific review panel? For example, to what extent does the percentile versus other considerations impact this program announcement?
Applications reviewed by study sections receive a percentile score, as do other applications. Early stage investigators may receive special consideration in funding decisions, but otherwise it's standard.
Next is, do R21s need to propose at least a 2-arm RCT?
R21s may, but they're not required to propose a 2-arm randomized controlled trial. The R21 is more exploratory in its mechanism, and as a result, applicants can propose an acceptability and feasibility study with the intention of designing a larger study to test the intervention that they're developing.
Okay. Next is, do applications need to include a data sharing plan?
So all applications, regardless of the amount of cost in their budget, do need to include a data sharing plan per the FOA, and I would refer them to the FOA for details on the requirements.
Yeah, can you please clarify whether a proposal that was submitted to the previous PAR 18-246 would be considered a new submission or a resubmission for this new PAR?
Yes. So applications that were submitted to the previous PAR, so that's 18-246, 247, but also 16-318, I think. So the previous version of the PAR would be considered a resubmission for this PAR.
Question is, how do you balance the three outcomes of caregiver well-being, patient health, and healthcare utilization? Can one be primary over another?
So you definitely can prioritize one over the other, depending on the goal of the research, the overall aims of the intervention, and the population. It's always best to consult with us if you want to talk through some of those questions.
Next we have, how can I be sure if my study meets the definition of a clinical trial?
So we have great resources on the NIH website, and on that resources page in the webinar today to determine whether or not your application meets the definition of a clinical trial.
Okay, next is, can the intervention or assessment improve outcomes for the patient and the caregiver?
Yes, they can, and we encourage you to consider the components of the intervention when deciding how to balance those outcomes.
Question is, I would like to use the NCI Community Oncology Research Program and Core Network to conduct my clinical trial in response to this funding announcement. Is there anything special I need to do if I'm going to use the NCORE network?
So there are additional steps that you need to take if you're proposing to use the NCORE network to conduct your study. This process does take additional time, so you must speak with the NCI and core staff before submitting an application proposing to conduct a study in NCORE. I suggest sending an email to me, Michelle Malika, first as soon as possible to let me know that you're planning to conduct your study with NCORE, and then I'll work with the NCI NCORE staff to set up a call and they can outline the process.
Okay. Next is, given that interactions with caregivers often occur outside the healthcare system, is it appropriate to include these settings in an application?
Absolutely. So community-based settings or settings outside the healthcare system are certainly appropriate. Again, it's up to the investigator to present their rationale for their chosen setting.
Next question is, are there suggestions for how to specifically measure healthcare utilization outcomes in applications to this FOA?
So this is a great question, and one that we certainly had in the previous PAR from investigators. There's many possible ways to measure healthcare utilization and health systems measures. We suggest having expertise in health services research represented on the study team. In addition, you might consider seeking input from the health system administrators or hospital administrators to discuss your proposed intervention, and measures that, if collected and showed improvement, might foster and facilitate implementation of those caregiving interventions. An important consideration is that the FOA states optimized healthcare utilization as opposed to reduced healthcare utilization. So, for example, in better supporting caregivers, that might actually lead to an increase in preventive healthcare visits, which would increase healthcare utilization, but perhaps would be ultimately more optimally utilized.
Next question is, the PAR asks applicants to consider sustainability and scalability in the development, design, and testing of interventions. Do we have to submit an implementation science application?
That's a great question. So we do ask that investigators consider the potential for sustainability and scalability. That does not mean that we're requiring applicants to submit an implementation science-based application, though applicants may propose the potential for scalability and sustainability as they consider the development, design, and testing of the proposed intervention.
Is an awaiting receipt of application or ARA required for the budgets that exceed $500,000 direct costs in any of the grant years?
So an ARA is required for budgets that exceed $500,000 in direct costs in any of the years. In our division, the Division of Cancer Control and Population Sciences, the ARA must be submitted at least 8 weeks prior to the submission date. So that means we suggest that you speak with us very, very early in the process so that we can work with you on that ARA.
Next is, how much pilot or preliminary data is needed for the R01 application?
That's a great question. So reviewers will evaluate the application for scientific merit. And for the R01 application, that includes an assessment of the rigor of the proposed research and the prior research, which is developed either by the applicant or cited from the literature. And that should support the scientific premise for the proposed project. So additional preliminary data should be sufficient to support any gaps and to demonstrate that the proposed approach is potentially promising, feasible, sufficiently rigorous, and that the applicant and their team have the skills and experience to conduct that research. Again, when there's a question of preliminary data, I suggest contacting us early to talk about that.
Next is, outcomes need to focus on caregivers and patients, but is it required to recruit both patients and caregivers as participants into the study?
So there's a lot of a growing body of research that says that intervening with the caregiver can improve outcomes and impact outcomes with the patient. So for this FOA, you do not need to intervene with the dyad, the caregiver cancer patient dyad. You must intervene with at least the caregiver.
Next question is, are new applicants who have not had prior NIH funding before encouraged to apply?
Absolutely. So investigators who have not had prior NIH funding are definitely encouraged to apply. We do have special considerations for early stage investigators, but when you're a new investigator, we strongly consider speaking to us early so that we can talk about your ideas.
Okay, and our last question is a letter of intent required, and what should be included in the letter of intent?
So So a letter of intent is not required, but it's strongly recommended for this PAR. LOIs should be sent at least 1 month prior to the receipt date and should include the title of the proposed activity, the names and contact information of the PIs, participating institutions, and the number and title of this funding opportunity. They should be sent by email with the PAR number in the subject line to me, Michelle Malika.
Perfect. Well, thank you everyone for joining us for today's webinar. And as I mentioned earlier, the presentation will be posted online in the near future. Please feel free to continue the conversation via email if you have any additional questions that were not answered during today's presentation. Thank you so much for your participation and have a good day.